All right, I think we're ready to get started. Good afternoon, everyone. Thank you for joining us for this webinar. The title is Using Data to Guide and Evaluate Responses to the Opioid Crisis, Rhode Island's Drug Overdose Dashboard. I'm your host, Susan Halpin. I'm the Education and Outreach Coordinator for the New England region of the National Network of Libraries of Medicine. I'm located at the University of Massachusetts Medical School in Worcester, Massachusetts. This webinar is being recorded. Those of you who registered for the webinar will receive a link to the recording and the presentation slides shortly after the webinar is over. It usually takes me more than a couple of days, maybe 5 or 6 days to get everything organized to send out that link. And again, if you need captioning for this webinar, the link to connect to the captioning is in the chat box. The webinar should last about 40-45 minutes. And if you have questions about what you're hearing or seeing, just jot them down and we'll save the last 10 to 15 minutes for you to ask your questions, and we'll have you put them in the chat box for us. For those of you who aren't familiar with the National Library of Medicine, oh, I'm sorry, I forgot to advance my slides here. Here we go. I just wanted to take a couple of minutes to give you some details about the resources that the National Library of Medicine has available, all of which are free. The NLM, which it's a shortened version to refer to it, is an actual physical brick-and-mortar library located on the campus of the National Institute of Health. It's the largest biomedical library in the world and one of the federal government's largest providers of digital content. The library is open to everyone. The mission of the NLM is to advance the progress of medicine and improve public health by making biomedical information accessible to everyone. The NLM carries out its mission through a nationwide network that has 8 regions, and the regions work with health sciences libraries, public libraries, and information centers. Each region has a partnership with a regional medical library, and its outreach is provided through the free access of online health and medical resources, free training and professional development, as well as grant funding opportunities. This slide is a listing of the substance use disorder resources we have available. And I just wanted to give you an idea of how comprehensive these resources are. So this is the screen from the first bulleted resource. And it's an example of how our resources are fact sheets, information about prevention, safety, and prescribing, patient materials, reports, and some of the topics related to substance use disorder that we have resources for, understanding addiction, medications to treat addiction, prescribing, pregnancy, neonatal, abstinence syndrome recovery, data, trends, and statistics. Now I'd like to introduce Brandon Marshall, who's our webinar presenter. Brandon is the Associate Professor in the Department of Epidemiology at the Brown University School of Public Health. He will be sharing his work with the Rhode Island Drug Overdose Dashboard. All right. Brandon, I'm handing it over to you.
Excellent. Thank you, Susan. Susan, can everyone hear me okay? Am I coming through loud and clear?
Yes, you are.
Great. All right. And I'm in control now, so we'll take it away. I'm happy to have this opportunity to present today and to share some of the work we've been doing in Rhode Island to address the opioid crisis in our state. What I'm going to do today is the following. These objectives will filter through the presentation, and then I'll be sure to leave some time for questions at the end. I'll talk a little bit about national and then focus on our state surveillance system to track and respond to the overdose epidemic. And throughout the presentation, we'll be learning about strategies to improve the collection, analysis, and dissemination of overdose-related data. I'm direct, as Susan mentioned, the Rhode Island's overdose surveillance system and dashboard Prevent Overdose RI. And we've learned a lot, I think, about what are our best practices for the communication of overdose-related public health data. So I'll share some of what we've done today, and I'm happy afterwards also to follow up with some additional resources if that's helpful for folks. So just to get a sense of the big picture for now, why we're focusing on overdose in this webinar. This is a graphic from the New York Times, actually, which shows you how the number of people who have died from drug overdose in the United States has increased essentially exponentially over the last 2 or 3 decades. The numbers when this slide were made for 2016 were preliminary. They've now been finalized at 64,000 people losing their lives to overdose in the United States in 2016. And that well exceeds, as you can see, the peak number of gun-related deaths that was observed in 1993 and the peak number of HIV-related deaths that were observed in 1995. So I often tell my students here at Brown that this could be and very well be the epidemic of their generation, much like HIV/AIDS was some decades ago. These numbers are so large, it's hard to get a sense of what that actually looks like. So another way to visualize the data, of course, is graphically or geographically. This is also from the New York Times using data from the CDC and maps at a county level the rate of drug overdose death here in 1999. You can see really hot spots popping up in West Virginia, parts of New Mexico, and Northern California. This is what overdose looked like in 2015, and the situation has gotten actually significantly worse since this map was generated. We see high rates of overdose really across the nation. This is an issue that touches essentially every community across the United States, rural communities, urban communities, red states, blue states. We all now, I think, are faced with addressing the overdose crisis. Nonetheless, you can see regions of the country that are more heavily affected than others, West Virginia, other parts of Appalachia, Ohio, the Southwest, New Mexico, and also here in New England. In addition to geographically, the drug overdose epidemic also affects essentially every age group. This shows you the rate of drug overdose death by age over time since 1999. Overdose used to be a phenomenon that primarily affected people in middle age. You can see in 1999 the highest rates were observed in the early 40s, late 30s. Over time, the epidemic has increased in all age groups, but most dramatically in the 25 to 34-year-old age group, and we're also now seeing increases in even younger teenagers and young adults. So that is tremendously alarming. It's driven primarily by the emergence of fentanyl in the illicit drug supply in the United States. Fentanyl is a highly potent opioid that is cut into illicit drugs and essentially increases the risk of death quite dramatically. And so now we see people, unfortunately, dying of overdose much earlier in a drug-using trajectory than what we used to see back in the late 90s and early 2000s. And just to finish this section now, I've pulled here the states with the highest rate of overdose in 2015 and 2016. In 2015, here in Rhode Island, we were actually 5th highest, Now, as you can see in this slide, we've dropped to 10th. And that isn't so much a reflection of significant decreases in our state, rather other states increasing faster than us. You can see dramatic increases in drug overdose deaths in West Virginia, the hardest hit state in the country, other states, and then the District of Columbia, alarmingly seeing almost a doubling of drug overdose in just 1 year. And down at the bottom, you can see how we've been increasing a little bit more slowly and have dropped in the rankings over time here in Rhode Island. So with that background in terms of the national scope of the overdose epidemic, I'd like to drill down now into how our state is addressing this crisis. In late 2014 and early 2015, our governor convened a task force, which consists of a number of stakeholders from various state agencies, members of the public, community organizations, and private industry. And they in turn tasked an academic research team to author a strategic plan. And I was fortunate to be part of that strategic plan. That was developed in 2015 and was released and endorsed by the task force later that year. I'm not going to get into the strategic plan in great detail today. I'm going to focus on how we use the data and the dashboard to drive targeting of our resources and understanding our epidemic. But just to give you a 40,000-foot overview, the strategic plan focuses on really what we call 4 pillars, where we feel we can make the biggest difference in terms of reducing mortality and saving lives. Prevention refers to the prevention of high-risk prescribing practices, high-risk opioid doses or high-dose opioids, and co-prescription of opioids and benzodiazepines, which was a significant issue in our state and in other places as well. Rescue refers to increasing access to naloxone. I'll touch on that a little bit later, actually. We're putting a lot of resources into improving access to treatment, primarily medications for addiction treatment, or MAT, and these include medications such as methadone and buprenorphine, and I'll come back to that in a moment as well. And finally, we're a national leader in peer-based recovery. I won't talk about this too much today, but we have created a significant number of peers who have experienced addiction themselves, are trained and certified, and are deployed throughout the state to meet people wherever they are and may be at risk for overdose, be that emergency departments, our prisons, or out on the street. And they make contact with those folks and try to engage them with services. So that's just a brief overview of our plan. Another important component of the plan, which I'll focus on now, is the creation of a public dashboard. We recognized very early that we wanted to be able to publicly track the state's overdose epidemic and be accountable to how we do in terms of addressing this crisis over time. So right away, very early on in the strategic planning process, we spent a lot of time developing data sharing policies, ensuring data quality, and then creating data management systems such that we could transfer data in near real time, analyze it, and present it to stakeholders and the public. So I'll talk a lot about that, how we did that today. First, though, I'll focus on just the goals of the overdose dashboard. These were identified through a stakeholder engagement process and through the drafting of that strategic plan. The initial conception that I had for the dashboard was that it would be a surveillance tool. We would just use it to track overdose-related events over time. It became obvious very quickly through that stakeholder engagement process that people needed more. They wanted a centralized resource for information on where to find resources, where to buy naloxone, where to seek treatment in their communities, and in addition to basic information about what an overdose is and how to respond. So the scope of the dashboard, as we call it, grew rather quickly through the stakeholder engagement process. And I'll show examples of those tools throughout the presentation. The second goal was to facilitate data sharing. Historically, data even in a small state like Rhode Island had been very siloed. The Department of Health has data sets, the Department of Behavioral Health has other data sets, the Department of Corrections, and it was difficult to share and importantly link data across agencies. And so we've created ways to eliminate those silos that I'll talk about today. We also use the dashboard to communicate emerging issues such as fentanyl. I'll show some examples of that. And as I mentioned, the final goal was to track our action plan, to hold us accountable, to make sure that we're making progress where we're putting resources and money into. A lot of people ask me, well, what did this actually take to accomplish this? Other states and regions are interested in these dashboards, and so I'd like to be upfront about what resources we needed to accomplish what I'll be showing you throughout the presentation. First of all, it took a lot of content expertise, both researchers such as myself, but also the community, stakeholders, community-based organizations that work with people who are affected by overdose or experiencing addiction. They were really central to developing the dashboard, as you'll see in the messages and the resources that we present. So we really worked on fostering community partnerships throughout this process. We convened a data working group to start to understand what the silos were and how we could eliminate those silos to share data more seamlessly. And all that took a lot of different types of expertise. It also took skill sets in terms of analysis and data visualization. And we collaborate here at Brown. We have data scientists that work on the website at Brown, but they work closely with the DOH and our Department of Behavioral Health, BHDDH, to visualize and understand that data. As you'll see, we use a lot of different data management and software tools. Many of our visualizations are done in a software called Tableau, which is actually a business analytics software program, which we really like. It's very web-friendly, and as you'll see, very interactive, and I think does a good job of communicating health-related information. We also use mapping tools such as ArcGIS and Google Maps to display information geographically. A lot of the feedback we got in the stakeholder engagement process was that people like to see information at their town level. How is overdose affecting my community, and what can I do to address it? So we try through our maps to be as local as possible in the presentation of the data. The website itself is just simply built in WordPress, so it's a fairly easy website tool to build something like this, and then some other database software such as SQL. And I'll talk about Stronghold, which is our secure computing environment, a little bit more. The funding for this, a lot of people ask me, comes from the CDC. We were one of the states to receive a prevention drug overdose for states grant and then a supplement as well. And so the funding for this project actually comes through that CDC grant. And I'm happy to afterwards give people some ideas how much it actually costs both to build the website and then to maintain it year over year. So just to highlight a little bit about how we eliminated some data silos that existed here in Rhode Island. All of this data, of course, is very sensitive on overdose deaths and treatment records, which I'm sure many of you know are subject to a lot of federal laws and are highly sensitive information. We used a resource here at Brown that was actually built by our Center for Bioinformatics called Stronghold. This is a secure computing and storage environment for all Brown researchers to analyze sensitive data. It meets the security requirements and controls for HIPAA and many other federal regulations. So Stronghold allows us to actually transfer individual level data from the state here to Brown and then do a lot of interesting things with it. We can analyze it within the Stronghold environment and also link the data sets together. I'll show you the benefits of those linkage projects in a moment. And this is really how we eliminated some of these data silos, was through this computing infrastructure. Everything is kept in Stronghold, locked down, and meets all of these federal requirements for sharing data. We also, of course, have IRBs and other policies that we developed with the state, for example, around sharing small numbers that we adhere to so that we don't inadvertently disclose data around small numbers of overdoses occurring in towns, for example. As I'll talk about now, Stronghold also allows us to conduct deterministic record linkages between data sets using identifiers such as names and dates of birth. And that's allowed us to evaluate some interesting programs and to conduct some great research, which I'll talk about now. So one focus for us is people who are recently released from the correctional system. We were able to link our state's correctional records with our overdose death data set to identify how many people are released from our prison jail system, and then they're dying within 1 year. And as you can see here, this figure shows you the total number of drug overdoses over time, shown in blue, and the number of people of those total deaths who were released from our correctional system within 1 year of our death. And as you can see, about 12 to 15% of all overdose fatalities occurred among decedents who were released from our correctional system recently. So that was a major issue for us and is an issue in many other states as well. So we developed an innovative program to address that data. We're the first state in the nation to provide MAT, methadone, buprenorphine, and naltrexone to all individuals in the correctional system who are indicated for these therapies. There's universal screening for opioid use disorder, and then initiation of these treatments for people who would like these therapies. And then these people are provided with referrals and access to community-based services when they're released. And this program really started in 2016, and we're starting to see the success of this program now. This was an article released just in February, a couple of weeks ago in JAMA Psychiatry. We again used that record linkage, which I talked about, to look to see over time, again, how many people are released from our correctional system and are unfortunately experiencing an overdose death within 1 year of their release. And what you can see, we just did a pre and post evaluation here. The first 6 months of 2016, the program was implemented mid-2016, and then we looked in the first 6 months of 2017. And you can see here the number of people who died of an overdose and who were recently released decreased significantly by 65% just in that short period. And we believe that's largely attributed to the MAT program in our correctional system. And that 65% increase has actually led to a 12% overall decrease in drug overdose deaths statewide. So this one program appears to be making important inroads into our drug overdose epidemic here in Rhode Island. And a lot of this, again, relies on the data to understand the problem, and then, as we're now doing, evaluate its success. And there's a program now to evaluate this program in more detail. So that's sort of how we do it in the nuts and bolts of the dashboard. And I wanted to highlight, before we get into some examples of what's on the dashboard itself, that managing quality and constantly improving this tool is very important for us. We receive ongoing feedback from members of the public. You can comment and provide us with feedback on the website, and that allows sort of ongoing monitoring. I also update the task force quarterly with how we're doing, having a look at the data, and then obtaining feedback on the website itself in that venue as well. I want to highlight that one issue we had to deal with when we first started the strategic plan was that we were receiving a lot of data and as sort of dumped upon us to analyze. And that's not really effective to understand how we're responding to an overdose epidemic over time. We really need standing data sharing agreements to support frequent data refreshes and website updates. So data is transferred to us through Stronghold on a set schedule. It depends on the data set in question. For overdose deaths, for example, we receive that information monthly. And that allows us to really keep on top of the epidemic and update the website frequently and sort of maintain its usefulness so people can check it and understand in, I wouldn't say real time, but close to real time, how we're doing and where the epidemic is. And finally, another thing we learned through our stakeholder engagement process and some additional evaluations we're doing, conducting qualitative interviews with people who have overdosed and who may have opioid use disorder, is that an emphasis on clear visuals, plain language, and data-focused messaging is really been effective for us. You'll see other overdose prevention websites which are very dramatic, very shocking. They have pictures of death and despair. And those were not seen as very effective by people who are most at risk for overdose and family and friends who are affected by overdose as well. People really wanted professional, focused messages that was action-oriented. What can I do in my town or with my family to help address this epidemic? So that focus on data-focused messaging, action-focused messaging, and plain language and sort of neutral language, I would say, really permeates the feel of the entire website. So without further ado, I'll show you the front page, the landing page of the website called preventoverdoseri.org. You can see here, again, very sort of a clean look, not a lot of dramatic images, and sort of neutral color and very clear messaging as well. And boxes below that provide audience-specific information. If you're a family, a friend of someone affected by overdose, a first responder, providers, or someone who needs help, there's resources specific to those groups. So this talk, though, is about data. So I'm going to focus the rest on the data we get and what we do with it. This is a summary of the data that populates the dashboard, preventoverdoseri.org. I've talked a little bit about our overdose death data set, which we receive monthly from the medical examiner's office here in Rhode Island, and we link that data to the Rhode Island Department of Corrections, as I've shown you already. We also track emergency department visits for overdose. In 2014, I want to say, the Rhode Island Department of Health promulgated a regulation that all ED departments, emergency departments, had to report suspected overdose cases within 48 hours of their occurrence. So that's called the 48-hour reporting system. Hospitals must report any suspected overdose case to us within 48 hours. So that data is collected by the Rhode Island Department of Health, sent to us on a bi-weekly basis, analyzed by my team at Brown, and then uploaded onto the website. And that's probably the most, I would say, close to real-time data set that we have, are those emergency department visits. We also work with the Rhode Island Department of Health, looking at data on treatment admissions through the state. All licensed substance use disorder treatment facilities provide information on all admissions to the Department of Behavioral Health. And again, we analyze that data and present it on the website in aggregate at Brown. We care a lot about improving access to medications for addiction treatment, or medication-assisted therapies, MAT. And so that data comes to us from a number of different sources: the PDMP around buprenorphine prescriptions, our Department of Health with opioid treatment program utilization, and also information federally from SAMHSA on physicians who are able, providers, I should say, who are able to provide prescribe buprenorphine in our state. Naloxone data is the final one. This is rather tricky. Naloxone is distributed through many different sources, so we've had to work with a lot of different institutions to build a robust naloxone distribution infrastructure. We work with the Department of Health, other agencies. The Department of Corrections distributes naloxone to releasees, community-based organizations, and we also receive information on naloxone distribution from the 3 largest pharmacy chains in Rhode Island as well. So I wanted to move now and talk a little bit more about overdose deaths, both at the national and state system. I'll talk a little bit about what overdose death surveillance looks like nationally. Really, the best place to find national overdose death surveillance is from the National Center for Health Statistics at the CDC, collects information on vital records through the National Vital Statistics System, or NVSS. And this program is a collaborative program. It works with all 50 states to receive data from states' vital statistics offices on death records and causes of death. They have a separate website now on provisional overdose deaths. As I'll talk about, they've improved the timeliness of this reporting system. So I encourage you afterwards to go to this website and look more at the national statistics on drug overdose death through this portal. So to talk about the system a little bit more, state vital registration offices sends death records to the National Center for Health Statistics. These deaths are reported by the jurisdiction in which the death occurred. So I should clarify that often in Rhode Island, well, not often, but sometimes we have an overdose happen out of state, but is transported to one of our hospitals and the death is pronounced in Rhode Island. That would be counted as a Rhode Island overdose and is reported to the national system through our Department of Health. Causes of death are coded according to ICD guidelines. Those guidelines have information both on the drug that caused the death and also the manner of that drug overdose death, be that an accident, intentional, a homicide, or sometimes undetermined. One of the major issues with this system is that there's a significant lag time between when the death occurred and when data are available for analysis nationally. This used to be around 12 months before data was actually submitted, analyzed by the NCHS, analyzed and then published. Those provisional estimates and that provisional website I showed in the previous slide now reports provisional estimates every 6 months. So that's about a 6-month delay. If you go on that website, you might see data through, say, August or September. A couple of limitations of this data set is that not all jurisdictions record the drug that caused the overdose in the same way. Some jurisdictions just simply say this death was an overdose of acute drug toxicity. A recent paper came out that looked at this process state by state and found that states actually vary tremendously in the degree to which they report the specific drugs that caused an overdose death. We actually do the best in Rhode Island. Almost essentially 100% of our deaths are coded as having specific drugs that caused that fatality, only around half the time in some other states. So you might have seen in the news last year that this does result in an underestimate of drug-specific fatal overdoses. The total number of overdoses may still be accurate, but if you drill down and look, for example, at heroin-related overdoses, those may be unreported in jurisdictions, and that's simply a function of the way that the cases are coded by local vital records offices and then reported to the National Center for Health Statistics. So to get around some of these issues, both timeliness and then also to get more detail on the drug overdose deaths, we work directly with the Office of the State Medical Examiner, the OSME. They are charged with investigating all unnatural deaths and send us their data, as I mentioned, on a monthly basis. And we work with the Rhode Island Department of Health to analyze those cases and look in more detail into what caused those deaths, the characteristics of the decedents, and even the exact address at which all overdoses occurred. So it's a very rich data set, which has allowed us, as I showed earlier, to do some interesting data linkages and some other analyses that are ongoing around the epidemiology of overdose in our state. The standard system I've shown sort of in this circle. The medical examiner will also, once they investigate the death, send that information to our state Office of Vital Records, which will update the death certificate and then send the death certificate to the CDC, which codes that death according to ICD-10 guidelines. And then that information actually goes back to the local jurisdictions, and the final death certificates are recorded. So again, this is a rather slow process. It takes 6 to 12 months. We are able to get the data monthly by working directly with our medical examiner's office in the Rhode Island Department of Health. So we'll focus now on some of how we've actually used this data. So one way is by looking at the data on a monthly basis, we can update our overdose death numbers more frequently. So this is our epidemic over time in Rhode Island from 2009. And the most recent data I pulled last week, the 2017 data shown in gray, includes data from January through November. So we're still on maybe a 3-month delay in reporting drug overdose deaths. And that's simply because drug overdoses take some time to investigate at the medical examiner's office. They have to conduct toxicological analyses and investigate witnesses to determine whether that overdose was accidental or intentional, for example. So that delay is still present, but as I've mentioned, we've been able to shrink it down and report our overdose statistics more frequently than many other states. We still have December to go to close out those cases, but projections we've done looks like we'll finish 2017 at around perhaps 305, 310, which does represent about an 8% decrease since 2016. Which is certainly not a huge success. We have a long ways to go here in Rhode Island, but I believe some of our efforts are starting to pay off, such as our jail prison MAT system. So this is the kinds of things we can do with such a rich data set. As I mentioned, we have information on where every overdose fatality occurs at the address level. Our team here at Brown aggregates that data to the zip code and then the town level and is able to present that information graphically on our website. This figure shows you the number of overdoses by town. The yellow indicates more overdoses. This was generated in Tableau, so it has a number of interesting features. You can mouse over towns and it gives you the count in that town and both the rate, and then the fields at the bottom allow you to actually toggle the graph on the website, and you can change the years, you can change the map to color the map by counts or rates to really drill down and allow you to see in your town what the rate and number is year over year. And we've had a lot of good feedback on this. People, again, like to know what the overdose epidemic looks like in their town. I'll just show briefly a couple of examples of other ways in which we've used the data. I want to focus on some of the naloxone and treatment maps now. This is another map we've put together, which we call a naloxone distribution tool, or the Narcan Figulator. As I mentioned, we collect information on naloxone distribution from many different sources, so we have a fairly good idea of how many naloxone kits each town is receiving in Rhode Island each year through all these sources, be that community, pharmacies, what have you. We're able to overlap that naloxone data on the opioid overdose death burden also at the town level and compare those numbers. So this map shows you a ratio, the number of naloxone kits that each town received divided by the opioid overdose death. So that's the ratio. And then the map allows you to set a target, somewhat an arbitrary target. In this case, it's 20. So we say each town, let's say the target is 20 naloxone kits for every opioid overdose death. This map gives you a quick way to see what towns have met that target here in 2017. So Providence, for example, in the middle of the state has, versus other towns that have not met that target, shown in yellow, more rural parts of the state. If you toggle over, you can actually see, for example, here in Westerly, in the southwest part of the state, 235 kits were distributed in 2017. This is a pretty rural town, and there were 6 overdose deaths from January through September. So according to that target, no more is needed. So it's not really the target that's important here. It's more a tool to provide community-based organizations information on towns that are under-resourced compared to their opioid overdose burden, and target or deploy resources to ensure equity of naloxone distribution across our state, focusing here on the towns that are yellow. We also have a lot of treatment information on the website. So this is a screenshot of our treatment page. We highlight a 12-hour-a-day hotline that people can call to talk to a licensed counselor to get referred to many different types of resources. We have information on detox, outpatient, residential, MAT, and other peer-to-peer programs across the state. All of this is displayed in a map, so people can look to see in their town where are the treatment centers, what is provided, what information, what their hours are, what their numbers are, and so forth. So this is an example of being able to provide local information to treatment resources at the town level. I'll just spend a couple of minutes now showing some examples of some of those other goals. So again, one way in which we use the website is to communicate emerging public health issues. For us, one example of that is fentanyl. Over 60% of our drug overdose deaths are due to fentanyl, so it's a huge crisis in our state at this point. So there's a lot of resources on the website specific to fentanyl, harm reduction messaging, and infographics that can be distributed through outreach teams or in other venues, such as at shelters across Rhode Island. So we've developed infographics that have clear messaging around what someone can do in the event of a fentanyl overdose. You know, carry naloxone, don't use alone, and call 911. Are really the messages right now that we're trying to get out to folks, both to prevent fentanyl and really all opioid overdoses. And finally, I'll show you an example of how we've used the website to track our action plan. So if you go to the Track Our Action Plan page on the website, you'll see a really clear infographic that describes what we're trying to do, which is save lives. Our goal was to reduce overdose deaths by 1/3 in 3 years. We're not there, unfortunately, I think largely due to the emergence of fentanyl. We've seen increases year over year, and now perhaps a stabilization of the epidemic in Rhode Island or even small decreases. But nonetheless, that original goal is made very clear on the website so people can engage with that mission. And then we track our progress. So as I mentioned, there are 4 pillars to our action plan. One of them is treatment. We want to increase access to medications for addiction treatment. We work with state agencies to understand how many people are receiving buprenorphine and also methadone. So here we work with the Rhode Island Prescription Drug Monitoring Program and the Department of Behavioral Health to understand month over month how many people are receiving these therapies. And this dashboard provides you with a quick tool to see, okay, buprenorphine, we are seeing increases. So far in 2017, the numbers haven't been finalized, but around 4,600 Rhode Islanders are accessing buprenorphine per month. Unfortunately, that's quite far from the original goal. In contrast, methadone has seen year-over-year increases, and we've actually achieved that goal. So through accessing these data, allows us to understand where we're doing well and where we need more improvements. What are the barriers to improving access to buprenorphine? Well, we've tripled the number of providers who are able to prescribe this therapy in Rhode Island. So we now have many more providers who can actually prescribe this medication, but we're not seeing massive increases in the number of patients that are actually being prescribed. So we're now working to understand what are the barriers at the provider level to actually screen for OUD and start prescribing this therapy. We can also look in more detail at some other targeted interventions. So in earlier last year in 2017, the Department of Health released regulations for standards of care for how to treat an overdose in an emergency department. One of those standards is that all patients coming in for an overdose should leave with naloxone. And so this data is from our 48-hour reporting system. Again, all hospitals are required to report suspected overdose cases within 48 hours of their recurrence. And one of the fields is, did the patient receive naloxone when leaving the emergency department? And here, what we want to see is more greens. Yes, that patient did leave with naloxone. And you can see that over time, and as those regulations were developed and then released and improved in March of 2017, we do now start to see increases in the proportion of all patients who are leaving with naloxone. We're still not there yet. It's still less than 50%, but it has been improving over time. Just to finish off now, we also use the dashboard to report monthly to the governor and other agency directors. We have a password-protected portion of the website which provides information sort of in a one-stop shop as to all of the metrics that we have for all of our various strategies and interventions, how we're doing well, on track, needing improvement, and so on. So we provide these monthly updates and use the website to communicate that data to high-level officials. This is what the password-protected page looks like. So there's some more sophisticated analytics that we've done, those action plan metrics that I showed on the previous slide, and some more advanced analyses of the overdose death data as well. So this is available to members of our task force, for example, community-based organizations that distribute naloxone, and other people who are really close to the ground on this issue. The public part of the website, we really try to keep very user-friendly and plain language. So this is where we put more of some of the advanced analyses that a typical member of the public might have trouble comprehending. We also look at website statistics. We're doing pretty well at this point. Our website is being viewed across the US. We've conducted technical assistance calls with 12 states now who are interested in this kind of approach. We've also seen consistent increases in the number of people who are accessing the website. What you want to focus here is the orange bar. These are the unique IP addresses who are accessing the website each month. Looking here at 2017 and the beginning of 2018, the number of unique IP addresses increasing from 680 to over 1,600. The blue bar shows you the actual number of page clicks per month, and the brown shows the number of sessions. So that's people who are kind of clicking around in a unique time-limited session as well. What we're starting to do now is actually to drill down and to use Google Analytics to understand how the page is being used. You can actually look to see how people navigate through the website. So we're hoping to learn how people click through the website and whether we could maybe improve the process through which people navigate it. But this is just a simple snapshot that shows you that people are interested in many different parts of the website. Our most popular page is actually the home page for the data. So people click on the data portal most frequently. The home page obviously is also very common. Prevent Overdose is the page where there's just basic information about what an overdose is and how to respond to an overdose. That's also very popular. About is about our state's response and this action plan, and then some other resources and other topics viewed fairly frequently as well. So that's all I have today. I'd like to acknowledge my staff at Brown. I work with wonderful a team of data scientists and other folks and students as well who actually have been critical in making all of those infographics that I showed you. We have a data working group, as I mentioned, who provide input. Staff and the director of the Rhode Island Department of Health are critical, and our medical examiner colleagues and my research colleagues as well, and of course funding for the CDC. So with that, I'd like to stop, and I'm happy to now answer questions. And I'll turn it back over to you, Susan.
All right, thank you, Brandon. I was happy to hear that there were other states that are interested in reproducing your dashboard. How many other states have approached you?
We've done 12 calls with local health officials or state health officials to walk through what we've done and how we did it. In terms of other places that have actually replicated what we've done, Staten Island has a wonderful bureau dashboard, which has been adapted from our approach, so I encourage people to look at that website. And also, Connecticut is developing a dashboard very similar to ours right now, and there may be others that I'm not aware of. You know, what I often say, and there are some other states as well that have more surveillance, like open data platforms, which are very helpful for researchers and people very close to the data to understand the epidemiology of overdose in their state. I would say the difference between a surveillance tool and a dashboard is where we need to visualize the data in a way that's understandable to any member of the public. We really want, it's not that we control the message, but we have to work very carefully to focus in on the most important messages and what data tells that in a most compelling manner. We show really only about 4 or 5 sort of data snapshots per web page. So rather than overwhelming people with lots of different information on subgroups and strata and whatnot, we distill the information to be as clear as possible for any member of the public and action-oriented.
Great. Brandon, I just sent a question to everyone that came across. Could you comment on why the target for methadone is lower than current capacity with goal for increasing I always pronounce that incorrectly,
buprenorphine, yes. So I'll go back to this slide, and thank you, I think, Mark, for that question. So the goals, which I should have mentioned here, are shown in green. We actually have to update this slide now that we're in 2018, but the green there is the goal. The goals were set by various work groups, and so people were responsible for coming up for the goals that we felt were realistic. So the opioid treatment providers and the Department of Behavioral Health provided us with that methadone goal, and that was a little bit different than what was set for the buprenorphine goal, which I believe was developed more by the Department of Health. So that's why those goals are different, is because different folks were involved in working to set them. In terms of why I think we were able to increase methadone capacity and achieve that goal, and we're struggling a little bit more with buprenorphine is a couple of things. We've had a long-standing and very robust opioid treatment program infrastructure. OTPs are where methadone is provided. And so I think when we developed the strategic plan, those OTPs were well positioned to start accepting more patients as we screen more people in the Department of Corrections, for example, and referred them into community-based OTPs. So they had the capacity to take those on. Buprenorphine, you know, we thought would be, can be an office-based therapy, and we maybe naively thought that by training more providers to prescribe buprenorphine and by having them go through what's called the wavering process and get a training waiver from the DEA, that they would just kind of start screening their patients and providing buprenorphine. And as we can see, that maybe is not happening as much as we'd like. One way to address this is we have developed what's called a Center of Excellence model for the treatment of opioid use disorder. This is adapted from the Vermont model. It's called a hub and spoke model. So basically the Centers of Excellence are specialized centers that can work with patients who maybe have comorbidities or are more challenging or unstable, can provide additional services, initiate MAT, be that methadone and buprenorphine. And the idea is that then once they're stabilized, refer them back to their community-based provider who could then continue that, say, buprenorphine therapy. And so those COEs are being launched across the state starting, say, earlier last year. And so we're hoping that once they get up and running, they will be able to provide the resources necessary for community-based providers to feel comfortable prescribing buprenorphine to patients.
Brandon, can you speak a little bit about how long this CDC grant will run for?
So that is I believe that's a 5-year grant, so we're about halfway through. As I mentioned, we started this process in mid-2015. So, you know, it is a question I do get asked. What is the sustainability of something like this? And it is a concern for ours. We're actively looking for additional funding resources to continue this work after the CDC grant funding ends. I do that in collaboration with the Department of Health, so they're applying for SAMHSA and CDC grants as opportunities arise. I'm also applying for research grants from the NIH to both use these data to conduct research analyses and also surveillance-focused projects. And so we're investigating currently a number of different opportunities to continue funding for this project in the long term. But I should say, when the CDC grant, prescription drug overdose grant for states was awarded, the Rhode Island Department of Health committed to this project for 5 years. So from the outset, we knew that we had at least 5 years of funding and support to build and develop a dashboard.
Great. Are there any more questions?
Oh, I do see one extra question, Susan, that I'm happy to answer here from Becky Gray. It's regarding the map of overdose locations. Let's go back to that.
Oh, here, let me make you the presenter.
There we go. So the question is whether the map is whether there's information on the addresses of the overdose locations or the home address of the person who overdosed. So the data set we have, we extract that information from the medical examiner's files, and those contain information on the address of the location of the overdose. That's often pulled from EMS calls or police reports. So it's basically where they responded. So that's where the overdose location occurred. Now, that's obviously highly sensitive data. So that's kept in Stronghold and is not released to anyone or members of the public. The map that I show here is an aggregation of those values. So we aggregate all that address level information up to the town level and then provide this. So this is information on how many overdoses occurred in that town in any given year, if that makes sense. And the second part of the question is Stronghold software something that is available for others, or is it proprietary? It is something that Brown developed. It's part of the university-wide computing and IT infrastructure for faculty and researchers to use. So it is a Brown-specific service, but in talking with colleagues across the country, many other universities are developing similar infrastructure, computing environments that meet federal regulations for HIPAA, for example. So if you're interested in this kind of work, I would encourage you to chat with your IT departments or computing departments at your institution and talk with them about whether they're developing such a resource or would be interested in doing so. I'm happy afterwards to connect with people. I think I had my email address up at somewhere, if you could flash that, Susan. People can email me and I can send more information on Stronghold, so then they can take that to their local institutions and see if there's something similar.
All right, Brandon, there were a few other questions here that I just noticed from Becky. Just verifying, do you map addresses of overdose locations or home address of the person who overdosed?
Yes, I just answered that question. It was it's the address of the overdose itself. Yeah.
Yes,
yeah.
I'm sorry. Next one. This is from Kate. Mapping of overdoses is very fascinating and really useful on a programmatic level. You mentioned that overdose deaths are recorded by jurisdiction in which the death occurred. Do you also look at the residency of the individual who died?
Yes. So we have information on the address of the overdose event and then the town of residency of that person. And we've looked at that data a little bit, and it's quite interesting. Rhode Island is a very small state. You can drive across the state in 20 minutes. But many people, I would say 70% of people would be my rough estimate. I'd have to update that. But many people overdose in their town of residence. It's a very local epidemic here, and I think it also speaks to the penetration of the illicit drug market in many towns across Rhode Island. In other jurisdictions, I've heard different phenomenon. Many situations where people drive to obtain illicit drugs and then either use in their car or drive back to their town. We tend not to see as many overdoses in vehicles, which suggests that there's not as much like large-scale movement of people obtaining drugs and then using elsewhere. The vast majority of cases in our state are people who either overdose in their own home or overdose in a home of their partner or an acquaintance in that same town. That would be the majority of the cases, I would say.
Okay, I have another question here from Becky Gray. What software program are you using for the dashboard? Is it ARC Online?
That's a great question. So this map in front of you now is done in Tableau. And I am a fan of Tableau. It's interactive. You can have mouse overs and change the map on the website. You know, epidemiologists are so funny. Epidemiologists love rates, but a lot of members of the public like counts because it's easier to communicate that there were 14 overdose deaths in Bristol, for example. And so Tableau allows you to actually change that map to see rates and counts and restrict year over year. So I really like its interactive functionality. It is expensive. The license, I think, runs about $1,000 a year. So that is the one downside of Tableau. It's really designed for business analytics, and we've started to use it for health information. The one other place where we use a different software would be the treatment map. This is, I believe, a Google Map API. So we use Google Maps here because it's better for mobile phones. The idea is that they could pull up a location, it shows the address, and then you can obtain driving directions. So we do also use Google Maps in some instances. For some of the research spatial epidemiological analyses, we do use ArcGIS, but that's actually, I don't think, presented anywhere on the website.
Okay. And Brandon, we have one last question here. This is from Lydia Cheng. Hi, thank you for this excellent presentation. I am a local epidemiologist for a city in Ontario, Canada, and I'm interested in whether you have any advice regarding data sharing linkages at the local municipal level rather than the state level?
That's a tough one. You know, Rhode Island is unique. It's a very small state. We only have state-level jurisdiction here in Rhode Island in terms of health. So there's a statewide Department of Health, no county-level health department or oversight infrastructure. So really much of what we do operates at the state level in collaboration with cities. But really most of what we've done is at a state level. I would say what we're encouraging now towns to do is develop their own action plans that are in alignment with the state action plan. So some towns have done that and have proposed very interesting and novel interventions that they feel are going to be effective in their own town, that kind of align with those 4 pillars that I mentioned. In terms of data sharing, unfortunately, I don't know very much about what that looks like at a town level in terms of sharing across towns or just integrating data sets at a town level. And unfortunately, all of this work really occurs at the state level, but I hope that's been helpful nonetheless.
All right, I think we have to end now. Brandon, thank you so much for this informative presentation. Everyone who joined us, thank you for taking the time to be with us. And we would love to hear your feedback about this webinar. There's an evaluation link that you can click on and give us your feedback. And if you're planning on receiving MLA continuing ed credit, you do need to fill out the evaluation in order to receive the credit. And there are some steps here that you can take to actually receive the credit. All of this information will be in the information with the recording link when you receive it in a few days. All right, we're going to end the webinar now. Thank you again, everyone. Bye
Thanks,
now.
everybody. Bye-bye.
Why can't I do that?
Do you have the presentation someplace else, please?
Yeah, I do. So let's see. It's hard for me to think this quick. Weird.
Or you're going to have to open chat again.
God. All right. No, you're helping me. Thank you so much. Thank you. Like, honestly, I wouldn't have noticed this.